a 52-year-old male presents with acute, severe pain and swelling at the base of the great toe. He has had multiple similar episodes over the past 5 years. I am showing you posteroanterior and oblique radiographs of the foot. Please describe the findings.
The radiographs demonstrate large, punched-out erosions with sclerotic borders and overhanging edges at the medial and lateral aspects of the first metatarsophalangeal joint. There is prominent medial soft tissue swelling and a mild hallux valgus deformity, with relative preservation of the joint space.
What is your primary diagnosis?
The findings of first metatarsophalangeal joint erosive disease with overhanging margins, dense soft tissue swelling, and preserved joint space are diagnostic of chronic tophaceous gout.
What is the classic clinical term for acute gouty arthritis involving the first metatarsophalangeal joint?
This is known as podagra, which represents the initial clinical presentation in approximately 65% of gout cases.
What key radiographic feature distinguishes gout from septic arthritis in a joint presenting with acute swelling?
Gout is characterized by the preservation of the joint space and bone mineralization until very late in the disease. Septic arthritis causes rapid, uniform joint space destruction and diffuse periarticular osteopenia.
Which other joints in the foot and ankle are commonly involved, and what is the typical distribution of gouty arthropathy?
It typically involves the tarsometatarsal joints, ankles, knees, hands, and elbows. Gout has an asymmetric, polyarticular distribution that predominates in the lower extremities.
What are the primary differentials for these punched-out erosions in the first toe?
The main differentials are psoriatic arthritis and joint infection. Psoriatic arthritis typically features bone proliferation, periostitis, and lacks the characteristic sclerotic borders and overhanging margins seen in gout.
What advanced imaging modalities can be helpful in complex cases to differentiate gout from other arthropathies?
Dual-energy computed tomography is highly useful as it can detect and color-code uric acid crystals. Magnetic resonance imaging is also beneficial for evaluating soft tissue tophi and the extent of joint disease.
Finally, what are your clinical management recommendations?
I recommend image-guided aspiration of the joint fluid for crystal analysis to confirm monosodium urate crystals under polarized light. I would also suggest referring the patient to a rheumatologist for long-term urate-lowering therapy.